Hello, everyone, and welcome. My name is Ann Sasson, and I'm the Program Director for Dartmouth Center for Global Health Equity. I'm pleased to welcome you to today's Pandemic Partnership for Equity of Information webinar. Today's session will focus on expanding hospital capacity and will be led by Dr. Jim Geiling. Dr. Jim Geiling currently serves as attending intensivist and hospitalist at the White River Junction, Vermont Veterans Affairs Medical Center, consulting tele-ICU physician for the Baltimore VA Medical Center and intensivist at the Rutland, Vermont Regional Medical Center. Prior to March 2017, he served 14 years as Chief of the Medical Service and Director of the Intensive Care Unit at the White River Junction VAMC, an affiliate of Dartmouth Hitchcock Medical Center. He was previously co-director of Dartmouth's New England Center for Emergency Preparedness, and professionally, he has served in leadership positions for disaster-related activities for both the Society of Critical Care Medicine and American College of Chest Physicians. Dr. Geiling has worked in many global settings, including Haiti and Tanzania. Today's session will be recorded and posted online. A brief document summarizing the information will be shared following the session. If you have a question or comment, please insert it into the comments section. We are able to take questions today in English, Spanish, and French. Thank you, Dr. Geiling, for joining us this morning.
Great, good morning. Thanks, Ann, for the kind introduction, and greetings to friends and colleagues. Good morning, good evening, wherever you might be, and a personal shout out to friends in Arusha, Tanzania, who may be online. So I appreciate the opportunity here this morning to go through some issues surrounding hospital capacity constraints. And these relate not only to the current COVID-19 crisis, but also other possible disasters that may occur, whether they be infectious disease, whether they be mass trauma settings and the like. So this will hopefully be applicable not just to COVID-19, but to other possible settings. So where are we going to go this morning? I think the important thing is to understand the current setting with COVID-19. The challenge is, yes, only 80% or so have mild symptoms, but 20% will end up requiring hospitalization, and we'll go through that in a second. Even in settings where medical care and healthcare systems are robust, these settings have challenges in managing the number of patients in the ICU beds that they require, oftentimes changing their standards of care from normal conventional standard of care to crisis standard of care. We'll talk about that as we go on. Lower middle income settings and even rural settings in higher income situations oftentimes have severe constraints in day-to-day operations, and the COVID-19 will further stress those systems. And so therefore, we actually need some strategies to how are we going to work in managing the surge of COVID-19 patients, whether they be the first wave or second or third wave, which is predicted in the coming months. So the objectives, what are we going to talk about? The roadmap for this morning. Let's talk briefly about the spectrum of illness of these patients. And then how are we going to manage these and triage who ends up coming into the hospital and what kind of resources are they going to need? How can we safely monitor them outside the hospital to perhaps mitigate or prevent or minimize the number of patients that have to come in? And if we do end up having a large number of influx, how can we expand the critical care capabilities of our healthcare systems? So the spectrum of illness. Again, 80% of these patients have mild or moderate illness. Typically, these are younger patients. They may be asymptomatic. We're learning that even though asymptomatic, they may be spreading the virus. But fortunately, most people will do well with this. 15% or so, based upon the data coming out of China, will need some critical care support, principally oxygen, and we'll talk about the levels of oxygenation that they end up needing. And 5% of these patients of the total population are going to require intensive ICU care, oftentimes with mechanical ventilation. So the resource intensity goes up as the numbers go down. So again, those who are mostly asymptomatic just essentially require some monitoring and making sure that they stay stable. Some may develop a cough and will end up requiring oxygen therapy, and this can be done in a less intense setting, but unfortunately 5% will require the most resource intense care, and that principally involves the institution of mechanical ventilation. So what are these standards of care? This was first described in 2009 by Dr. John Hick and colleagues, and sort of validated in Mike Christian's paper there, referenced below. Typically what happens is if we have a bus accident or we have some other mass trauma setting, conventional standards of care can usually be applied to most patients if you expand or have suddenly 20% more patients than you normally see in your facility. You can quickly adjust the operations that you're having and provide essentially the same quality of care for a brief surge. When you start to get doubling or so of your hospitalization requirements, this is when we sort of move into contingency standards of care. Suddenly we have to start conserving the IV fluids, watching who gets oxygen, making sure we don't throw away gloves that we might normally do, and we might have to reuse some things and adapt to different strategies. When the numbers become totally overwhelming, as has been seen, for instance, in Italy and New York City, we get into the challenge of crisis standards of care. Here's where we're really struggling, when we just don't have enough resources to provide even sort of normal critical care capabilities. And not only we are conserving and substituting, but we're reusing and potentially even reallocating and deciding who gets the support and who doesn't get the support. And this is the greatest challenge. A lot of effort has been talked in the literature and in the press about these crisis standards of care. It's important to understand our goal is to prevent getting there in the first place. How can we optimize the care to the left of this graph so we never have to get to the right of the graph? And we'll talk about different strategies and how to achieve that. So what is essential critical care? And those are cases that require advanced critical care, and they unfortunately have generally poor outcomes. Most settings have very limited critical care capabilities, and mortality can range up to 80% in some settings. But fortunately, if we address, again, some of the clinical problems that patients have early, we might be able to reduce the number of cases that require advanced critical care and not only improve their outcome, but also can decrease the stress and strain on the healthcare system. So those interventions might include giving oxygen in a less intense setting and preventing them from spreading the disease, perhaps having the patients laying on their stomach, having physical therapy, and monitoring them closely. So in order to mitigate this, we sort of look at this from the framework of essential critical care. And we look at this by two sort of strategies on the left-hand side. That is, how do we identify the critical ill, and how do we provide care to the critically ill? As far as identifying them, we'll talk about hospital readiness by using pulse oximetry, some triage systems, and training of healthcare providers to identify who is really sick, trying to interpret what their clinical syndrome looks like, and therefore identifying who is going to need the service. And as far as providing that care, making sure the hospitals are ready with oxygen, applying it appropriately. And if we identify both the number of patients, who the patients are, and the care that they're going to need, then we can effectively provide that essential critical care, stabilize them, and hopefully provide and improve the survivability. Now, for the triage criteria and resource constrained settings, symptoms that require hospitalization include patients who have low oxygen saturation. This, of course, implies that somebody has a pulse oximeter available. So we'll talk about perhaps another way or workaround. But if a person has saturation less than 94%, we should need to think about them starting to be monitored for possible need for oxygen therapy, remembering that normal would be sort of in the 98 to 100% on room air at sea level. If you have pre-existing illness such as COPD or asthma or pneumonia or other pulmonary symptoms, you might need them to be seen at an earlier stage. Clearly, if they have trouble breathing, pain in their chest, they have some mental status changes with confusion, they have clinical evidence of hypoxia with blue lips or face or nail beds, if they have pneumonia, mottled skin, if their urine output begins to decrease, they're coughing up blood or increased amount of sputum, chest pain, or any other worrisome symptoms that would prompt them to call an ambulance or have their family take them to the hospital, these patients obviously need to be referred, and the public health campaign needs to make sure that the community understands these symptoms. How do you detect silent hypoxia? Typically, these patients have low oxygen but normal carbon dioxide, so they don't often appear breathless, or they may not have the normal signs and symptoms of hyperventilation, and therefore they have this challenge of being silently hypoxic with low oxygen levels. One way, of course, the gold standard would be to put a pulse oximeter on their finger, and that can help them. You can help detect that. But there's this other tool called the Roth Score, and I personally had to look it up myself, and there's some different videos and things out there. It was in essence described by a cardiologist from Tel Aviv. You ask a patient to take a deep breath, and this can be done, for instance, over a telephone. You ask a patient to take a deep breath, and in their native language, start counting 1 to 30 or higher as fast as they can. If they require a deep breath or to catch their breath within 8 seconds, then you become concerned that their oxygen level at baseline is pretty low and they might be at risk. And particularly if they have to catch a breath in 5 seconds, then there's pretty good data to show that they have a pulse oximeter well less than 95%, and these patients might want to get referred. There's some controversy surrounding that, but I would offer that when a pulse oximeter isn't available, these kind of tools may be beneficial and help in figuring out what's going on with your patients remotely. Clearly, if they have saturations below 92 in the absence of underlying illness, or 94 or below, if they have underlying illness, then these people should be referred, and also should have their temperature taken. We typically talk about it twice a day, and to look for silent fevers, because those folks may also need to come in to be seen. So we've looked at the spectrum of illness. We know the 5% that are going to end up requiring critical care. We've looked at some of the triage criteria, particularly hypoxia or dyspnea, using tools such as the Roth Score. Now, how do we get to monitor and triage these patients before they come into the hospital? So the first is, of course, to self-monitor at home. Most of the patients can do this at their home and do not require medical attention. But again, this requires a community education plan so that folks are aware of what they should be looking for and what should require either them to seek care or to have their family members seek care. The community-based monitoring, therefore, expands upon that, and community health workers or other providers might be able to go out and follow patients, particularly if they have comorbid conditions. In the US and other places where you might have, for instance, the elderly living in a single facility together, these institutions, which have unfortunately had significant numbers of cases and deaths, should probably require a community-based monitoring system. And last but not least, we might be able to take care of the telehealth and telephone consults to prioritize the high risk for those who might rapidly deteriorate, such as those who are over age 65 or comorbid conditions. And these don't necessarily need to be high-tech solutions with video teleconferencing. It can be a simple phone call or check in with a neighbor. And we might be able to do that. For instance, using the Roth Score that I just described can be done over a simple telephone. The challenge is monitoring these patients from home is the secondary transmission. We've seen where up 17% or so, if a patient is in their home, can transmit this to family members if they don't observe strict quarantine or isolation procedures, where if patients do strictly adhere to these requirements when they are home and they are sick, then they significantly decrease, if not zero, much less secondary transmission. And that's our goal, is to identify these patients, monitor them at home with the help of community healthcare providers, and therefore mitigate the secondary transmission of the disease. As far as the home-based care for the disease prevention, obviously we want to protect the healthcare workers who go to see these patients, and they need to be providing with adequate PPE, and we'll talk about that some detail later. Develop some protocols to limit community household transition and transmission. These may require isolation and quarantine sites for the care of patients in exposed contacts. So perhaps cohorting these patients might be appropriate in the community setting. And clearly everyone needs to be washing or sanitizing their hands, minimizing outings, not touching your face, wearing a face covering such as a cloth mask in public. Recall that the cloth mask in public does not prevent the wearer of that mask from getting the disease. The wearing of the mask is to help prevent or mitigate transmission of that person of the virus that they may have on board and are asymptomatic, and prevent their transmission into the community. And of course, social distancing to try to avoid keeping 1 to 2 meters apart. And one nice tool I've seen is hold your phone out at 1 arm's length, and you should keep people 2 or twice the arm's length away. If you've not seen Tim Baker's work before, I introduced this as the vital sign directed therapy protocol. When patients are identified and they do begin to present to either community health care worker or the emergency department or the district hospital, how do you decide who is sick and who is not sick? And a lot of attention is being made to different laboratory tests and the like, but this is a nice way of looking at strictly at vital signs to try to determine who's really critically ill and who's not. It provides a protocol to routinely check vital signs, not just in the ICU, but on the wards and in the emergency department, and standardizes emergency care for those with abnormal vital signs. And briefly, you can look at this later. The reference, if you go to the reference, you can actually download and print this up as a PowerPoint slide for your emergency department. You look at airway, breathing, and circulation, and under those, you look at Glasgow Coma Score, airway sounds, respiratory rate, their inspired oxygen and their saturation, their heart rate, and their systolic blood pressure. And depending upon the numbers that you get, you can decide that a patient is relatively stable or that they might have deterioration, and therefore give you a warning that these patients might end up needing hospitalization or intensive care therapy. And this is all based essentially on just vital signs without any addition of laboratory data. Okay, so we know how sick people are getting. We've been able to triage who's going to come in and how we're going to monitor those patients. And now we are faced with the situation of the patients are presenting to the emergency department, and how are we going to provide the essential critical care that we described several minutes ago. I like to look at this as a model that's been described several years ago in stuff, staff, and space. That is, what are the things, where are we going to do it, and who is going to provide the critical care. And we'll walk through some of those capabilities and give you some ideas, and then we can answer any questions later on. So the first is, let's looking at space. How do we reallocate healthcare resources? First, have a plan. This can't happen, and it should ideally not be happening when there are many patients in the emergency department or in the community, and now you're suddenly scrambling to figure out, where am I going to put these patients? So anticipate the surge and anticipate how you're going to change your facility and where you're going to be able to put these patients. Perhaps repurposing different settings, endoscopy suites, recovery rooms, expanding critical care spaces. Perhaps there's back rooms in the emergency department. Perhaps there are rooms if there are less children or if there are less surgical cases, we might be able to reallocate some of those spaces. Perhaps designating specific COVID-19 facilities, that is cohorting these patients. This has happened in several places in the United States and one facility that I work at. And then lastly, there might be outpatient settings that you can convert into additional treatment space. The challenge always is, we know that the number one thing that these patients need is oxygen, and where and how we provide that oxygen can be really challenging when it requires, in your facility, moving around large oxygen tanks. Field hospitals can be helpful. Ideally, most people talk about using field hospitals to help offload relatively stable patients from fixed facility hospitals. That is, use normal hospitals for the most critically ill and use field hospitals for non-COVID patients. They can provide non-ICU level care or non-COVID patients. These might be temporary structures such as tents, or they could be schoolhouses, worship locations, and the like. As you've seen in the United States and other places, you can turn these into intensive care units, but it requires a lot of resources. Just imagine trying to get oxygen into one of these tents. So again, these can help offset the support and the need in the hospital, and put, for instance, routine postpartum patients, they could be managed easily in one of these field hospitals, and also not put those patients at risk for being in a hospital where there are many COVID patients. So that's space. How about staff? Well, some staff won't show. They'll be scared, they'll be afraid. And so I'd offer that training your people, providing them enough PPE, making sure that you'll take care of them, documenting who's coming in, will go a long way to making sure that you have the staff to take care of these patients. And this may require even some innovative things like, how can the community help with childcare, or even taking care of pets? Those things may prevent healthcare workers from coming to work. Perhaps non-active or retired nurses and physicians may be able to come in. They may not provide the most critical care, but they could certainly help with non-critical care patients. Rapidly train non-clinical providers to help with basic nursing care, housekeeping facilities. We're going to need a lot of computer support for the like. So helping to train them may be really helpful. And lastly, depending upon where you are, armed forces or other EMS and outside personnel may be able to help. Perhaps in your community, there would be nonprofit organizations or humanitarian workers. They might be elicited to sort of help out. So that's space, staff, and how about stuff? And this you've seen is real challenging as far as how do we provide adequate PPE. Typically, as you get into contingency and crisis capabilities, you don't have enough for one mask for one person. So for instance, in one facility that I've been working at, you wear one N95 mask for all day. When you go see patients, maybe you can put another surgical mask over top of that, but you use the same mask all day. At the end of that day, you put it into a paper bag, and you hang that paper bag somewhere where it's dry, perhaps where there's UV light, just so that it sits, because we know that the virus will die in several days. The next day you get another mask, and every 4, 5, or 6 days, you can go back to that mask. Other people are coming up with processes to use hydrogen peroxide, UV light, other ways of conserving these masks, as well as gowns and gloves and the like. So again, it's really important to think about how we're going to address those supply chain challenges, and think about them before you even face the challenge. And last but not least is an ethical framework for triage. This is where we don't want to get. We don't want to get to a place where we have one ventilator and 2 patients, and we have to decide who gets that ventilator. Nevertheless, it would be wrong for us not to think about how we might end up facing those challenges when we really have too many patients for the resources that we have on hand. And this should require not just, again, first come, first serve, but require a diligent, thoughtful process before we're faced with this problem. Because the allocation of care and resources based solely on factors such as age or gender or economic status or social worth, if you will lead to inequities of care. How are you and your community going to do this? There are several models out there of using perhaps scoring systems, perhaps triage officers, so that there is a system in place to prevent the bedside provider from having to face these challenges when you have two patients short of breath right in front of you. Need to disseminate these guidelines in advance and protect the staff so that they know what we're going to be doing. Have a triage committee to help support these decisions. That triage committee should require not just healthcare workers, but administrators, perhaps clergy, religious people, and members from the community to sort of, okay, this is the standards that we're going to apply in our community. Important, if we don't have the resources to provide to all these patients, that we don't abandon patients. All patients deserve appropriate care and comfort, and this may require palliative care resources to sort of help those, particularly those with comorbid diseases, for instance, the elderly or the demented who may not survive the use of essential critical care, and perhaps provide other means to make sure that they are comfortable during their illness. And all protocols and decisions should be transparent and make sure that the healthcare providers are aware and protected from any community or litigation things. So in summary, we've talked about identifying and monitoring the patients at risk and who might deteriorate, using the pulse oximeter or perhaps the Roth Score to help decide who's going to need to be supported. How are we going to monitor those patients, both in the community and once they get into the hospital? How are we going to care for them in the hospital? And then how are we going to reallocate resources, expand resources, and plan for the challenges in facing this pandemic? There's been a lot of great references that are provided here, and I encourage you to sort of seek those out. And it's a changing field. What I tell you today might change a little bit tomorrow, particularly in the specifics regarding healthcare provision, but it's a moving target. Hopefully, if we practice some basic public health perspectives and practices, we can mitigate the impact on our healthcare facilities and on our staff. And with that, I thank you very much, and I look forward to opening your questions.
I have some questions from the participants. So the first question is coming from Haiti, and the participant is asking, should we recommend the use of pulse oximetry at home for patients quarantined due to the risk of silent hypoxia?
So thanks for the question on pulse oximetry at home. The answer is pulse oximeter is the gold standard. So if you have enough pulse oximeters, then it should go to patients who are at risk. So I think it really comes down to a resource challenge into who has the pulse oximeters. I would offer that perhaps the greater utility of the few number of pulse oximeters might go, who are those patients at greatest risk? For instance, it might be in a facility where you have a lot of elderly who are living, and you might have a pulse oximeter and a community-based healthcare worker or nurse in that facility. Using the 1 or 2 pulse oximeters in that setting might be more useful in helping figure out who's going to get sick, rather than randomly distributing them, because we know that 80% of the people aren't going to need the health care, and therefore we don't want to use those pulse oximeters on 80% of the population who would never need further therapy.
So the next question that I have is asking about PPE recommendations for community health workers that are engaged in monitoring COVID-19 patients.
So PPE, so it is Classically, contact and droplet precautions, and you should review those with your local healthcare facilities. But in essence, you should have masks, coverings over your face, gloves, and gowns. Those should be the basics. You expand it to aerosol protection with N95 masks when you start engaged in aerosolizing procedures. And I would offer that those providers who are doing testing where you're doing nasopharyngeal swabs or oral pharyngeal swabs, which might induce a cough in a patient, then those need to have airborne precautions and the use of an N95 mask. Really important with PPE is not just what you as a healthcare person are wearing, but the process to put it on, called doffing, and the process to put it on, called donning, and the process to take it off, called doffing. Those really need to be practiced and rehearsed, because particularly in taking it off, the doffing of the PPE, that's when oftentimes the wearer of the PPE will become self-contaminated. So there are great diagrams and descriptions and videos out there on how to do that. And I would encourage people to rehearse that before you just put this on. And also it's really helpful to have an observer, that is a safety person, stand there and say, okay, with a checklist, you take this piece of equipment off first, and then the next one, you wash your hands in between, and make sure that people strictly adhere to that so that they know how to properly use their PPE.
Our next question is coming from Peru, and it pertains to maternal health. And I will note that we have some materials on maternal health that we're happy to share with this participant as well as others on the call. This participant is asking, what strategies would you recommend during and after a cesarean section when we learn that a patient is COVID positive?
So right now, as I understand it, there is no evidence of vertical transmission from mother to child. So that's a good thing. There is evidence of transmission of mother to, so there's no vertical transmission mother to fetus. There is evidence of transmission from mother to child. And so I think that even as recently as news programs last night here with the approaching Mother's Day, was a case of a mother who had delivered twins, but was socially isolated and she was COVID positive and was socially isolated from her children, her twins, until she became asymptomatic. So I believe that's probably the most appropriate way of thinking about this. As far as managing the pregnant, critically ill patient with COVID-19, I think the strategies are the same for pregnant patients as they are for other patients. A healthy mother will lead to a healthy baby. And so the same critical care skills and care provided is really important. When to time for the C-section and the like would be, is still an unknown. In other words, do we wait for the mother to become so critically ill, and when do we deliver? And where is the patient in their pregnancy? That's still a moving challenge, and I think we'll still have to figure that out.
I have another question, this one coming from the US. Much of the current data for the level of care needed for patients is coming from settings with older populations. Do you have any sense of what the distribution of patients who need critical care may be in settings with younger populations?
Yeah, I don't have that data right off the top of my head. Clearly, those who are at risk greater than 60 or 65, those with comorbidities such as hypertension, obesity, COPD, coronary vascular disease, and the like, clearly they are the ones who are suffering the greatest from this illness. But we've all seen the anecdotes, and I've cared for patients in their 30s and 40s who have done poorly and required significant amount of ventilator support. So again, the vast majority of those requiring critical ill are the elderly and or have comorbid conditions. But there are these smaller percentage, I can't give you an exact amount, but smaller percentage of who appear to be otherwise healthy patients, athletes, 40-year-old marathon runners who become critically ill. Some of those require prolonged hospitalization stays, and some recover, but oftentimes not. So it's still a moving target as to what is the the genetic makeup of patients that puts them at greater risk for becoming critically ill.
Thank you. I have a follow-up question from Haiti. How much do you think we can rely on the Roth Score for silent hypoxia assessment, as we know there are limitations on the score for acutely ill patients?
Yeah, I read one. Again, I did not know what the Roth Score either was until recently, and I looked it up this morning, and there's a couple papers and editorials out there describing that it's not useful, and that should not be used sort of as a screening tool for COVID-19. And the only reason I threw it out the conversation, and I'm sure that this will be changing and perhaps there will be other scores that will come out, is what do you do in those settings when you just don't have a pulse oximeter? And many of you are in those settings, and I clearly have practiced in those settings. What other ways can we sort of monitor these patients? And I would offer that the Roth Score isn't a gold standard, but I could also say that it would give you a tool to sort of help monitor a patient. If you can count from 1 to 30 before you need a deep breath, and you just are diagnosed with COVID-19, and now 2 days later you can't get through, 6 or 7 seconds, I would offer that you're getting more clinically ill, and therefore, as a tool, it has sort of given you sort of a spectrum of where you are on this curve, and might give you some clues to, okay, now's the time to come in, as opposed to just a straight point on the one-time evaluation.
Thank you. I have a question coming from Peru. What recommendations on assessing respiratory physiology in patients at high altitude can you offer?
Boy, that's a great one. So I would offer that I think we're going to need help with folks who live and work at high altitudes to help us understand the pathophysiology of COVID-19 in these settings. The numbers on the pulse oximeter that I described for you are at sea level. So, if a person's baseline normal saturation is 98 at sea level, and it's in the 90s, lower 90s at the altitude you're at, then those patients probably, if living at altitude, probably have increased red cell mass and can tolerate lower saturation levels, particularly if they don't have comorbid conditions. But again, that's something that we're going to have to figure out. And I would offer that it's not just the pulse oximeter, is what else is going on with the patient. Perhaps their normal pulse oximetry at your altitude is 90 or 92, and now they're at 85. If the respiratory rate is fine, if they don't have difficulty breathing, if they can count from 1 to 30 without taking a deep breath, I'd offer that patient is relatively stable as opposed to others that can't. So again, it's going to help if we have a spectrum of the disease over time, and we can monitor it over time with these tools as opposed to just one measurement.
I have another question coming in. Can you comment on the requirements for oxygen therapy and different strategies for increasing that capacity?
Yeah, great question. There's 2 points in oxygen therapy. One is obviously the supply, and then the second is the modality and how we give it to the patients. So one concern in the management of oxygen therapy is sort of aerosolization. And so early on, we've sort of talked about if a patient suddenly becomes hypoxic on nasal cannula or a face mask, that we ought to rapidly transition to intubation and mechanical ventilation, because A, we know these patients will deteriorate, and B, we don't want to give them a therapy that aerosolizes their secretions and makes it worse for where you're at. If a patient is not in an airborne isolated room, then we need to think critically about how you do this. So for instance, typically in a patient who has increasing respiratory distress, you might go from nasal cannula to a face mask, to high flow nasal cannula, to non-invasive ventilation with BiPAP before you get to intubation. The challenge, particularly with those last two, especially non-invasive ventilation, is that the patient may be aerosolizing. So you have to protect the surrounding healthcare providers and other patients if that modality is used. One trick that some people are doing is a nasal cannula, face mask. If you have high flow nasal cannula, requires a special machine, a lot of oxygen. If you have that capability, you may be able to use that and prevent the need for mechanical ventilation. But to help prevent it from aerosolizing is put the nasal cannula on, the high flow nasal cannula, and then a surgical mask over the patient. It's not 100%, but that may be one way to help prevent the spread with these high flows of oxygen before you end up intubating the patient.
Do we have any additional questions? I have an additional question coming in from Haiti. CPAP or BiPAP, what is the best for non-invasive ventilation in COVID-19 patients?
Right, ideally you would like to know, so this is a hypoxic illness, and when you sort of do chest x-rays or chest CTs, you'll see sort of the ARDS alveolar infiltrates. And typically, I would say you could do CPAP, and that is probably the simplest way of doing it. Clearly, if the patient is having hypoventilation and the carbon dioxide level is going up, if you can measure it, then BiPAP may be beneficial. But I would offer that most patients who are going on non-invasive ventilation require very close monitoring, because the vast majority of these patients are going to end up requiring intubation.
So I have another question coming in about the use of ventilators. This participant would like to know what outcomes that countries that have experienced the surges have seen so far, and what low and middle income countries might expect to see in terms of patient outcomes.
Yeah, unfortunately, you know, the mortality of going into an intensive care unit has been as high as 80% at some times in New York City and in Italy. So even, you know, those settings that are have the greatest resources have faced extraordinary levels of mortality in critically ill patients. So in resource poor settings, whether that be, you know, rural America or other locations that don't have enough resources, I think it's really important that we think about how are we going to allocate these resources to the patients who have the optimal chance of survival. And that's one of the triage conversations with that last slide to think about. We don't have a perfect tool yet is to predict who will have the best outcome. Some have offered that the SOFA score, the sequential organ failure assessment score, may be useful. Others have debunked that theory. We don't have a perfect score. So I think the institution and the healthcare system and the community will have to decide who is going to get those resources, how long they stay on the resource before you realize that it doesn't work. Patients who go on a ventilator often require 2 weeks of ventilator therapy before they get better. So this is not something that you put them on for 72 hours and expect them to come off. It is a resource-tense care for a long period of time. So therefore, the goal is to actually make sure that we reach out, we try to optimize the health care of the patients who are asymptomatic or have minimal symptoms. If they do have symptoms, isolate them. For instance, if a young person is out working in the community because they have an essential job, they're in the market, they're in the factory, they're trying to do their job and take care of their family, and they come down with symptoms, it's critically important that they not take that home to grandpa or grandmother who's sitting at home, because if they do, now those grandma and grandpa become your patient, and now you're challenged with the challenges of providing critical ill to them. So that's where we have to sort of focus on. Regarding the specifics of mechanical ventilation, I think we're going to have a conversation in 2 weeks on more details on providing what are the specifics of providing critical care, and the like to these patients. But real quickly, it's treat them with ARDS strategies, low tidal volumes in the 4 to 6 cc's per kilogram, and use fluid restriction therapy. We don't want to make these patients too wet, and we can go into more details in a couple of weeks.
Do we have any questions? I'm not seeing any additional questions coming in, so I'd like to thank you for joining us today for this session, Dr. Geiling, and I'd like to thank everyone who joined us. We have participants on the line from Haiti, Tanzania, Peru, Honduras, Kosovo, and other settings, as well as from the US. We will be in touch with all of you with a document summarizing the information that was presented today, as well as information about our next webinar. Thanks again to everyone.
Great. Thank you all. Have a nice day. Stay safe.